So this evening, the topic is Community Education Series, Dialectical Behavior for Families. This is our third event. This series is to serve family members, providers, to provide more information about mental health and the modalities that we're using to treat our clients. As I said, this session will be about DBT families. So before we get started, I want to just give you a brief overview of Clearview treatment programs. We offer a full continuum of care. We were founded in 2000, still independently owned and operated by Michael Roy, licensed clinical social worker. We offer detox, residential, and outpatient treatment. Where you're seeing today is our treatment center for our women's program with borderline personality disorder and emotion dysregulation. We offer comprehensive DBT in all our programs, but also are focused on evidence-based modalities. We're doing CBT, seeking safety for trauma, prolonged exposure for therapy. And so this program is 15 beds and for women only. And we track in groups of 8. Each client will receive up to 3 individual therapy sessions a week. They see the psychiatrist weekly. We have a dietitian on staff for those who are struggling with EDs, although we don't treat them as primaries, we often do see them as secondaries. About 2 blocks away, we have our co-ed residential dual program, which is primary addiction, co-occurring mental health. Also providing comprehensive DBT, but not everyone is appropriate for DBT modalities, so we do same CBT, seeking safety. You're also getting 3 individual sessions weekly, seeing a psychiatrist, also dietitian available. What's that? Sorry. Blinding you. Step down is our outpatient center in Westwood, which is, we offer a PHP program, IOP, and outpatient program. We are in network with Anthem Blue Cross for our residential dual and our PHP and IOP. Back in August, we just started our evening track, which is very exciting. Mondays, Wednesdays, and Thursdays from 5:30 to 9. And that is primary addiction or co-occurring disorders, and that's 2 groups a evening. And let's see, what else do we got here? I think that's about it. So I'd like to introduce our presenters tonight. Our first presenter, actually, I think they're doing it together. So Kate Roaring received her master's degree in clinical psychology with an emphasis on marriage and family therapy in 2012 at Pepperdine University in 2012. Kate is a licensed marriage and family therapist. Kate has also been a member of the Clearview Women's Center team since 2002, starting her work as community counselor and moving into the position of house manager. As house manager, Kate worked closely with the treatment team to ensure each client's experience upheld Clearview's mission and values. Kate has been a DBT therapist and skills group facilitator at Clearview for several years. She facilitates DBT skills groups and CBT groups and provides individual therapy and skills coaching utilizing DBT. Kate is trained as a National Education Alliance for Borderline Personality Disorder, Connections leader, and co-leads the family program here at Clearview. Our second presenter is Nicole Riddle. Nicole Riddle received her PsyD in clinical psychology from PGSV Stanford PsyD Consortium in Palo Alto, California. She completed her postdoctoral fellowship in behavioral medicine at Harvard-UCLA Medical Center. Dr. Riddle is trained as a National Education Alliance for Borderline Personality Disorder Family Connections leader. At Clearview, Dr. Riddle facilitates skills groups, provides individual therapy using DBT, and works with patients suffering from eating disorders. Dr. Riddle also runs an ongoing DBT skills group course for families, clients, and Clearview patients. Without further ado, I present to you Dr. Nicole Riddle. And And then also, at the end, if you have any questions, we also have Liz Korstein from our admissions team. So if you have any questions about the intake process, admissions, and insurance, she'll be able to answer those questions for you as well. Yeah, okay.
I can't see. You won't.
Yeah, no, I can't. Okay, off. There's the light. Sorry.
No worries.
All right. Thank you, everybody, for coming. I know it's probably been a long day, and many of you have probably traveled, even if you live 2 miles away. It probably took half an hour to an hour to get here, so we appreciate that. And so what we want to do tonight is give you guys some information on family work when it comes to DBT. And as Michelle said, Nicole and I run, along with Liz Korstein over here, we run the family program here at the Women's Center. So a lot of what you're going to hear tonight is part of what we incorporate into that program here. That's a 5-week program that we offer to loved ones of clients who attend the Women's Center. So what we want to do is give you some information on really family involvement and research and just a better understanding, psychoeducation on people who struggle with emotion dysregulation and what that looks like as far as people who may struggle with BPD, traits of BPD, or substance use disorders, because it really all kind of falls under the same umbrella of trying to cope with emotion dysregulation. So we're going to give you more information on that, as well as some skills that can be helpful as family members or loved ones, or just trying to get more information, for yourself around struggling with being a family member or a loved one of somebody who is experiencing emotion dysregulation. So the first thing that we want to talk about is that families are really, really important when doing the work in DBT. Now we've had, just as Michelle was saying, this is the 3rd series that we've had in the consumer series, education series. And the first one was talking about signs and symptoms of BPD, and one of the things that we went over were there are a lot of myths that are out there. One of the myths is that families don't need to be involved in treatment and that it's often not helpful, and that it could not be further from the truth. That it is so important to have family involvement, especially when we're talking about DBT, that is a huge piece of the work. And that research really shows that when there is family involvement, that there's a decrease in the level of burden and grief that often goes with just navigating the experience day to day with somebody who's really struggling with mental health. And it increases their level of mastery to be kind of in on this process and to be able to be, so to speak, in the soup with them and working through it together. So it's extremely important to have that involvement. And like it or not, what we do impacts each other, and that goes both ways. And so we're going to talk about that more tonight as well. And it's so easy to get in this push and pull and this polarity where we may be on one end of an argument and our loved one may be on the other end. And it's so heated and so important to try to come to this synthesis. And so part of what we want to do is also talk about that there's a big piece of DBT, where it got its name, is dialectics. So as it can be so easy to get pulled in these opposing, polarized positions with our loved ones, it's important to try to find a synthesis in that, and that's what dialectics are. It's having these two opposing things that can both be true at the same time, and instead of trying to get somebody to come over to your understanding of the argument or getting pulled over to their understanding of the argument, it's finding that synthesis and that middle path between. And the reason that we want to do this is that it can really alleviate a lot of the dysregulation that comes up and that push and pull, and it can help us to have some empathy and better understand each other. So an example here, which I'm about to go into a little bit more, is that I'm doing the best that I can, and I can do better. So that's the dialectic. So while I'm doing the best I can, something that seems completely opposing to that is that I can do better. And that's really the essence of DBT and part of what we really try to bring into the family work, is that we are where we're at, and we want to keep striving to do differently where we need to, and to do better. So elaborating on that, we have these things called the DBT assumptions. These are things that we ask for our clients to really be mindful of, and we as therapists and the staff here also are trying to be mindful of this. These are assumptions that help us when we get in that place where we feel really stuck, or we feel burnt out, or we're on those opposing sides, that these things can help us to get a little more wiggle room and to feel more empathy and compassion toward ourselves and our loved ones. So we always want to try to hold the assumption that we're doing the best that we can, clients are doing the best that they can with what they have in the moment, which could be a lot of vulnerabilities going on. That clients want to improve. I don't think I know anybody that feels like they're in this intolerable hell of dysregulation and suffering, and they're okay with that, that they want to be there. They want to improve. And to do that, we need to do better and try harder and be more motivated for that change. And that is something that really comes from DBT with the different modalities of therapy, is that we really work to bring about that motivation to change and to support it as it comes up. And patients may not have caused all their own problems, and when we tell clients that feels really relieving. Okay, I didn't cause all my own problems, and then you say the second part of that, and it's like, oh. Okay. But they have to solve them anyway. So it's important to come back to that too, that yeah, I didn't cause or create all of this turmoil and this suffering, and it's really on me to work through this and to get the resources and the tools to be able to move through this. The lives of suicidal borderline individuals are unbearable as they are currently being lived. That one's really important to come back to as well, especially when you're in that push and pull with your loved one and it feels like, oh my gosh, they know what they need to do. Like, why don't they want to change? And they do. There's just so much that comes up that makes it difficult. And to come back to remembering that, oh my gosh, it's insufferable feeling like this. This is a horrible place to be. And patients must learn new behaviors in all relevant contexts. That's where we learn skills. There's a skill acquisition period, and then we learn how to apply the skills. And then we've got to learn how to generalize them and apply them to the areas that are relevant outside of treatment and outside of working with your provider. And that patients or clients cannot fail in DBT. That DBT may not always be the most effective approach for everyone. It's definitely not a one-size-fits-all kind of therapy or treatment approach. And sometimes when clients, if they're not ready for the treatment, or maybe it's just that this isn't the approach that's super helpful for them, that it feels like they're failing. But you can't fail in DBT. That's something to come back to as well, especially when there's that judgment that can come up of feeling like you're not making enough progress.
Hello. So Kate's gone over kind of the approach that DBT takes and the philosophy that, in essence, DBT asks us to take when we're looking at what the person who has emotion dysregulation is going through and their experience. And then I'm going to talk a little bit about how we in DBT create understanding about how this all came to be. So the biosocial model or theory is the way that DBT describes what is kind of the origins and what are the things that kind of maintain the person's symptoms and their symptom presentation. And basically this is the story of nature and nurture. So again, we have another dialectic where we have the fact that everyone comes to this world biologically, genetically, falling on a continuum of temperament, from people who are on one end of the continuum that are very stoic to the other end of the continuum where they're very hypersensitive to the experience of their emotions, and then of course the people kind of in the middle. And so people who struggle with borderline personality disorder tend to fall on the end of the continuum where there's a really strong experience of their emotions. And then you have this transaction, this interaction between the person and their environment. And I'm actually jumping ahead in the slides, so that's, oh, this is special.
We got fans.
I know. Okay, well, let's go back. I'll back up and accommodate the slide. So we have, we have this interaction between the person and what they're bringing to the table biologically and their environment. And what ends up happening is that when we fall on the more kind of hypersensitive to emotion ends of the spectrum, we have a very strong response to things in life in general, that, you know, it's subjective. What people would say is something stressful to one person is stressful, not stressful to another. But the person has a really strong response to a situation, and then there's a quick or reactive kind of behavior usually that comes along with that, and then a really slow return to baseline. So I always give the example with this that in grad school, when I was really busy a lot, I would lose my keys. And so I would be trying to get out the door, and of course it would be like last minute, and I'd be like, where are my keys? You know, and then I'd be freaking out, and I'm gonna be late, and it would take me, you know, like 5 seconds actually to find my keys, and then I'd be driving and I'd have to like kind of be like, okay, that was stressful, and bring it down so I can get to class and be focused. And so people who struggle with BPD, they wouldn't really come down from that for the rest of the day. And then something else happens that, again, subjectively is stressful or not, and that kind of shoots the person up again in terms of having a really intense emotional response, and maybe they snap at someone that they care about, or they avoid something that needs to be done, and they don't come back down to baseline, and then there's a repercussion from that. And so all day long, there's this kind of, you know, down but spiking back up, down, never going all the way down, spiking back up. So if you imagine going through that all day, that's exhausting. And it makes it really hard for the person to make effective decisions about how to take care of themselves and how to interact in relationships, because it's hard to even take into account the person across from you if you're not feeling grounded and holding on to yourself. So now we get to the other side. So then we have this transactional piece going on where this person is growing up, and as a child, they may be in a family where the family members have a totally different temperament, so they don't understand necessarily what's happening. The child is pre-verbal and can't describe like an adult, well, I'm upset because, you know, blah, 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 and I need you to help me self-soothe. You know, 3 and 4-year-olds aren't gonna say that. And so you have this experience where the child ends up inadvertently feeling invalidated. It's not that the family members are proactively trying to invalidate the person. It's what we call a poorness of fit in terms of temperament, that you have, and this isn't just parents, it can be aunts, uncles, grandparents, siblings as well. Or the parents understand, but maybe there are things going on in other aspects of the environment, school, you know, the area that you live in, what have you. So there's all of these kind of stimuli that the child interacts with, and because of their temperament, if they're people in their environment who don't understand or don't know how to model, how do I take care of myself given this temperament, then there becomes this pervasive sense of I'm not okay as I am. And not only am I not okay as I am, I don't know what to do about it. And that's where people start getting into, and Kate will talk more about the maladaptive coping behaviors, because they're trying so hard, like Kate saying in the dialectic of, everyone's doing the best they can and wanting to change. They're trying so hard to figure out how to take care of themselves, and people end up falling into maladaptive behaviors for various reasons that we'll talk about in a bit. So we have this transactional model going back and forth. That's an example of inadvertent invalidation, and then we have more, I guess what you call proactive invalidation. So there's a lot of times kind of this idea that people with borderline personality disorder have to have had some kind of trauma experience, and that's not the case. They've done various studies to demonstrate that that's not the case. And there are people who have had trauma experiences, and that's been a more kind of proactive invalidation, whether it's childhood abuse or bullying or prejudice and segregation, or trauma from war zones or immigration or what have you. So various kind of experiences. Keep you on the toes.
Alright, so what this looks like with the biosocial model, if we were to depict what happens, is that there's this interaction between the biological piece of having that sensitivity and high reactivity and slow return to baseline, and then the environment not knowing how, or just not supporting that experience in a way that feels supportive. And over time, what that leads to is pervasive emotion dysregulation. So the person internalizes what they're hearing and feeling from the environment, and so they judge their emotions, they don't trust them, and they don't know how to regulate them or manage them. And then we find these different ways to manage it, and that's where you see things like substance use, we see self-harm behaviors, we see it in these 5 areas. Marcia Moynihan, when she reconceptualized the different traits of BPD, plugged them into these 5 areas of dysregulation. So when we have this umbrella of emotion dysregulation, we also see it kind of seep into these different areas of our lives. So there's emotion dysregulation, where you see that there's these pretty abrupt changes in emotion that happen pretty, they're labile. And a fast start of the emotion, big experience and expression, which we just talked about with the biosocial model. And then there's avoidance of the emotions and numbing. So that might be where you see things like substance use, is to try not to be in contact with the emotions because it's so painful and such a really big and uncomfortable experience. And if you don't know what to do with that, you're going to try to find ways to manage it. We see dysregulation in relationships. So there's some chaos in the relationships. There may be moments where a person is really put on a pedestal and very highly valued, and then there are times where that can change to feeling like this person is just, I'm cutting off that relationship completely. There's also a fear of abandonment that can be real or imagined. It can come from a place that there's a lot of sense we can make of that of course that is a valid fear for you to have. And then that gets translated into other areas where we don't understand why it would come up. It doesn't make as much sense because this person is just going to the store and they're coming back, for example. So there's this fear that could be coming from a very real place that gets kind of superimposed onto all these different relationships and experiences. There's self-dysregulation, where you might see somebody struggling with their own identity and sense of self. Chronic feelings of emptiness, low self-esteem, and self-judgment. We see that quite often. There's behavioral dysregulation, and that's where we see the self-harm, suicidality, impulsivity. This is where we would also see potentially substance use as well. And then there's cognitive dysregulation or thought dysregulation. So you would see dissociation or checking out. This is really common in BPD, and the level of which the person experiences dissociation is really impactful to their daily life. There's this fear that bad things are going to happen to you or to somebody that you care about. There's difficulty problem solving, because I don't know if anybody's tried to do something that's particularly difficult to mentally think through, like a math problem when you're feeling really upset about something and it just doesn't happen. Because when we're that dysregulated, we don't process new information. That's what sets a person up who experiences pervasive emotion dysregulation, is that we often will go to try to problem solve something when we're so dysregulated it's just not possible. That part of our brain is not online. And the interpretation of events is thrown off, it's skewed. So there's a misinterpretation of events when a person experiences chronic dysregulation.
So here at the Women's Center in the Women's Residential and PHP level care program, we see the behavioral dysregulation category manifest in various ways, and we think about it as whatever behavior the person's doing that really impacts like their physical being in a harmful way to suppress the emotion, dysregulation, or the discomfort that comes from the chaos in the relationships or the lack of sense of self. And so that can come up in terms of self-harm. It can come up in terms of eating disorder behavior, and also in terms of substance abuse, like Kate was saying earlier, that the way that DBT conceptualizes the substance abuse behavior is that the person is trying to numb out from their emotions to manage and to kind of keep going, or even kind of just taking a break from life. So we treat this just like any other what we call target behavior, which is a behavior that we're focusing on helping the person to change, usually to decrease. We'll also look at things that people are doing well and we want to enhance that. But usually when we say target behavior, it means a behavior that's problematic for the person, and we want to decrease the occurrence of using that behavior to manage their heightened hypersensitivity to emotions, and going into learning the skills from the modules as a way to handle things instead. So this model gives the idea of what ends up happening for people is that you have some kind of stressor, and then there's that heightened emotional response that I was talking about before. And then there's an appraisal or a thought of the stressor. I can't handle this, I can't tolerate this, I have to reduce it, I have to avoid experiencing it. And then that leads the person into having what we call an action urge, that urge to engage in a behavior, and then following through with that behavior. And then as a result of doing that behavior, they have a very quick, immediate shut it down. And that's why these behaviors are so compelling and hard to stop, because they work quickly and they provide relief really quickly. The problem is that the after effects are really detrimental, whether it's after effects in terms of emotions of guilt and shame and sadness and fear and loneliness, or kind of situational after effects like being rejected, being isolated, losing jobs, not being able to follow through with things in life that would also help the person to have a strong sense of self and self-esteem. So this, I think, is really important because a lot of times with behavior change, we say to people, oh, you should just do that, done. And we don't take into account what drives the behavior. And we don't get into this in this talk, but just kind of letting you guys know that in individual sessions, we spend a lot of time in something called behavior chain analysis on the whole kind of chronological order of thoughts, events, emotions, body sensations, and other actions that get the person to that maladaptive behavior, so that we can really kind of break it down and see where to intervene. And also in terms of addressing the secondary emotions and what have you, we'll talk about what are the positive consequences of the behavior and what are the negative consequences. Again, that dialectic, so we're holding both, and the person, it feels validated by, we understand why you're still going towards this, as well as asking you to really look at and acknowledge the negative consequences and why we want to do differently. So when our emotions get the best of us, the better of us, we end up having this heightened emotional arousal and then an inaccurate, sometimes self-expression. So we might convey, if we think about like primary and secondary emotions, there might be a primary emotion of fear, but then we end up conveying the secondary emotion, maybe because it feels more comfortable, maybe because that's just ends up being what we've done over the years and how that comes out. And so then in the interaction, the relationship, you have this person who's having this kind of response, and so we see that and we respond to it, and then the person says, you don't understand me. And so this is where Kate's going to talk about the importance of mindfulness skills in communication. Mindfulness for the person within themselves to really check in with themselves to make sure that they're expressing accurately what's going on for them, or that they're able to even identify that there's a mismatch in what they're presenting, and for the person who's on the receiving end, conceivably the family member, to use mindfulness skills to recognize that there's a moment there where we may want to be curious with the other person, and it may be that going into problem solving change isn't the place we want to go right away. We might want to stick with validation and things of that nature. Oh, just kidding, I'm doing this first. So before Kate talks about mindfulness skills, what I was describing is wise mind. So DBT describes that we have 3 emotion states, and not like concretely this narrow, but that we tend to have an experience where we have emotions and our emotions drive the experience. And this is really important in terms of passion and creativity and the arts and, being able to feel alive and excited about things. So those are kind of the positive parts of emotion mind. Where emotion mind can get off kilter is when we start just following that, and maybe we get reactive and impulsive and we're just kind of all limbic system. And so then we have on the other end of the spectrum reasonable mind, which is our logical, analytical, like no emotions, just the facts, way of kind of accessing and approaching things. And that can be really important if you're building a bridge. We want that. However, there are other times in life where we want to have both, because if we go with just the facts and just logic and kind of just, push for that, then we might be hitting our head up against the wall around certain things. So wise mind is the idea of holding both of those together and considering both. And I think in all relationships, really, this is true, that there's a bit of the rational and there's a bit of the emotional, and not 50-50. I'm sure we've all been there. And so, but we really, the mindfulness skills help us to be able to recognize which state of mind we're in, and that if it's in our values in that moment, to be in a wise mind place, helping us to try and get there. This can also be superimposed onto understanding what happens for people when substance abuse is a struggle. And these are swaps. So addict mind should be where emotion mind was. And so in terms of substance abuse being the behavior, addict mind is that place where we sit, where everything is driven by trying to find the substance, trying to use the substance. That is the focus. And again, that usually coincides with impulsivity, reactivity, very emotion driven. And then you have clean mind, which is the idea that the person is maybe not using, or maybe they're trying harm reduction and it's not really working for them. And it's this place of kind of naivete. It's that place where you say, oh, it's fine, it'll be fine, it's fine, and like the house is, falling down. And it's a tricky place that people who are first in sobriety, it's a place to be very careful about, and it's something that we'll talk a lot about with a term called dialectical abstinence in our groups about addressing addiction or any behavior where there's addiction. So that's a place that we want to use our mindfulness skills to be aware of, am I in that place where there's danger around me, but I'm wanting so badly for everything to be okay that I'm just kind of dismissing the signs. And then clear mind, again, is being able to hold both. So if we can acknowledge that there are urges and there are cravings, or we're maybe going into situations where we're around people that are perpetuating our use or could perpetuate our use or make our sobriety fragile, being aware of that along with the awareness of the possible naivete. And then we have clear mind balancing both. Okay.
There we go.
Yeah.
Alright. So a really important place that we want to try to start, and this is the foundation of DBT, is mindfulness. That for any skill that you will learn in DBT to be effective, it's important to be mindful while you're using the skill. Otherwise, the skill probably most likely won't be as effective as it could be if we were using mindfulness with the skill. So mindfulness is its own set of skills here. And we're going to talk first about just how to use it and how to understand it for yourself, because it's important to have that connection to ourselves and our experience in the present moment in order to be able to use skills also with our loved ones or other people in our lives. So we'll talk about just regular old mindfulness and also relationship mindfulness. So there are different components to mindfulness as far as DBT goes, and one important component is non-judgmental awareness that we want to take in without putting any kind of assessment or evaluation or judgment on it. We want to take in the stimuli from the environment that we're experiencing or what we're observing in the environment or with the person with whom we're interacting or what's coming up for us. So we first observe. This is just without putting a label to it at all. Just noticing with your five senses. So if I were to put my hand under a running faucet, I'm just going to notice the pressure of the water, the temperature of the water, those things. I'm not going to think at this point, the water's cold. That's a description. That is describe. And those things, though they seem to happen simultaneously, there's actually a space between us experiencing it and then us putting a label to it. And we teach this, and it's important because of that impulsivity and reactivity that comes up with pervasive emotion dysregulation. It's so important to find that space between, because that's where we find that moment where we notice what's going on, we feel what's going on, we see it or experience it in an interaction, and then we have that moment after that experience where we can put the label to it, and we can slow down and decide what to do next. Rather than reacting, we're trying to move toward responding to what is coming up for us or what we're observing. So we want to observe, we want to take in the stimuli, we want to put a non-judgmental description to it. What happens when we put judgments on something is it most of the time will increase whatever emotion we're experiencing. So if I have a really not great day in program and I go and I talk to somebody on the phone, let's imagine I'm a client, and just like what Nicole was describing a little bit ago, that transaction that happens where there's an inaccurate expression because we're feeling so dysregulated, we might call up our loved one and say, I just had the shittiest day in program. My therapist doesn't care about me. The groups are stupid. Nothing's getting better. So I don't know if anybody's heard that from any, yeah. And then you might get an invalidating response because the person on the other end doesn't really know exactly what all that means, and their emotions go up, and there's probably a history of that kind of interaction, and you're not really going to get the need met that you're trying to convey. So with mindfulness, we want to try to slow down and notice what's coming up for us, and to be able to put that non-judgmental description to it, so then we're really accurately describing, not just for somebody else, but for ourselves, what's going on, which is going to help reduce our dysregulation rather than heighten it. Because if we're even saying that, we might be amping up our loved one, but we're also amping ourselves up by saying those kind of things. So it's important to try to slow down and respond to what we're experiencing. Yes?
So what would you say as like a parent or caregiver to the person that is saying, I had a horrible day and my therapist was bad, and rather than trying to solve it and get upset too?
Why don't we
Stress that
use that as an example when we get to validation?
Yes.
Because
Perfect.
you just said it, that we don't want to go into problem solving,
Yeah.
we want to go into validation.
Yes.
So yeah,
Okay.
Yes, that's a great example. And the last component is to fully participate in the current and present moment. So we may feel like, well, if I'm here and I'm doing this, then I'm participating. I'm always participating, and that's not accurate. What this means is to be fully in the moment and having your one mindfulness be a part of that, throwing yourself fully in and not thinking about something else or worrying about what people might be thinking of us, or judging ourselves. We're just all in this one moment. And then the effectiveness in action. So the other piece here is that we want to really try to maintain this non-judgmental stance and also consider what makes the most sense in this moment. Not what might be the easiest, not what might be the thing that feels good. What might make the most sense to have this not get worse? And that's effectiveness. So that typically isn't what feels best or easiest. That's why skills are so hard a lot of the time, because choosing to be effective means we're choosing the more difficult, the more tiring and exhausting path, because the other behaviors are often, just as Nicole was saying earlier, they're quick and they work quickly as well and get that relief. So mindfulness is being able to slow down, observe our experience, describe it non-judgmentally, and fully participate in whatever it is that we're doing. So they break them down in DBT into the what skills, what we want to be doing when we're mindful, and the how skills, how we're being mindful. And that's what I was just describing. So when we are being mindful, we are observing, we are describing, and we are participating. And we want to do this through the how skills of taking a non-judgmental approach. When Nicole and I teach this, and Liz teaches in the family program, we talk about to try to maintain that non-judgmental stance. Think of it as if you were a security camera on a street corner, what would that see? It wouldn't see a girl who's sad or a person who's sad standing on the street corner. Sadness is an evaluation or a judgment. The security camera would see a person that's standing there, their shoulders are slumped, they're looking down, there's tears coming down their face. So non-judgmental stance is really thinking about how to take those evaluations out of it. Sometimes that's helpful to think of it in that way. And we want to do this one mindfully. This is so important because again, mindfulness is the foundation of DBT and it's really what makes the skills effective. And so if we're taking all this energy and time to try to use skills rather than go toward one of those ineffective coping behaviors, and we're sitting there working on something to distract, let's say we're doing a crossword puzzle to try to distract from the thoughts that are really upsetting to us. And instead of fully focusing on that crossword, we're kind of reading it and then we're thinking about the thing that's really upsetting and the reason that we're doing that. And that's not being mindful of the skill that we're using. We've got one foot in the skill and one foot back in the other. And that means that the effectiveness of it is really going to be greatly reduced. And then effectively, which I went over a moment ago, that it's just thinking about what makes the most sense to get through this without things getting worse.
So we want to apply these skills in the interactions, in the moments that you're having with your loved ones, with the idea that there's a hope that maybe if we try to interact in a certain way, we may not prevent all the blow-ups or all the misunderstandings or all the difficult interactions. We might enhance the ability for one another to stay in the moment, to tolerate the interaction for a longer period of time, and to really be able to hear one another. Because one of the things that can be really challenging with that quick, strong response and slow return to baseline is that we can lose people really quickly. And then the conversation essentially should be done, but I think we don't practice effectiveness, we keep trying to push through and then, things escalate. So this isn't to say that there's any one perfect thing to do. But like with your example, the first step would be with the mindfulness skills to recognize, like in hearing the person on the other end of the call, okay, they're really like amped up right now. So this probably isn't a time where if I try to like insert some kind of change oriented idea that they're gonna hear it. Because again, it's that idea that the limbic system kind of throws a tidal wave over the frontal lobe and the person really isn't in a place to take in problem solving because so much like that's coursing through their body is emotion line. And so if we can, and we do this in our interactions in session and in group and what have you, it's our use of mindfulness skills too to kind of recognize, is this person available for this feedback right now, or do we want to wait? So, and again, it goes back to effectiveness with the hope that they're going to be more likely to really hear me if I wait and try and pick up on those signs. And the other piece too with this is that if we're reducing the amount of times that we're having validating responses, the person also might come to worry less about having an interaction and being invalidated. Because that's also what can happen for people who struggle with BPD is there's like selective attention bias or hypervigilance for being invalidated. So it like puts them on edge, and then it's already like, they're already getting close to that, you know, heightened emotional response anyway, because they're worried that they're already gonna be invalidated. So we wanna try and use the mindfulness skills in those situations. And hopefully then that transactional model will shift and the person will have lowered emotional arousal. That will allow them to connect with their mindfulness skills and hopefully have more accurate expression. And then with the relationship mindfulness, the other person has lowered emotional arousal and can access validation. We'll talk about that in a minute, but it's really hard to validate when you feel pummeled emotionally, I guess is how I would say it. So if the other person is kind of on the attack because they feel attacked, even though that's not our intention, then, you know, everyone's like, and then it's really hard to validate when you're like this. When you're like this, you want to do it right. So we want to use our mindfulness skills to recognize that our dukes are rising and try and like bring them down and try and think about how can we kind of like lower this, the intensity of this, and validation can be a way to do that. So. But I think I said this. And there has to be empathy and willingness. That's the big part. So again, going back to that piece that Kate was talking about, ineffectiveness, if we can hold on to, and with the DBT assumptions that even though we may be on the receiving end of something very difficult, that this person is in a lot of pain. That doesn't mean that it's appropriate to stand there and be yelled at or what have you. It's trying to find some empathy that our loved one is struggling in this way and they don't necessarily want to, and trying to kind of find a middle path and meet them in the middle so that everyone can be more effective with one another.
Alright. So back to this idea from the very beginning is that what we say and do impacts the person with whom we're interacting and vice versa. And so we want to take a really close look at how we can use mindfulness to get to this place where we can validate, which validation I feel like can be like a magic trick if we're able to do it effectively, because it can really, really de-escalate a situation that could quite quickly and maybe in the past has gone off the rails. So what research has found is that validating parent behaviors are associated with more effective emotion regulation and greater satisfaction in that relationship. That what validation really is that it's allowing somebody or communicating clearly your understanding of somebody's experience, even if you actually don't understand it because you've never lived it. And it's being in the moment with the person. And as humans, that's what we really want, is that connection, that feeling of understanding and feeling heard. And so validation, when it's done in a way that gets us to that place, it really, really can take things down and allow for there to be a different kind of conversation and interaction. And research has also found that when we go in the other direction and, inadvertent or meaningful invalidation, we see that that is associated with higher externalizing behavior problems and lower relationship satisfaction. So, acting out and doing things behaviorally that just, escalate the situation. So validation again, as I was saying, it's being in that moment with the person and really clearly communicating your understanding of what they're saying or expressing. Establishing or substantiating an emotional experience, a behavior, a thought that the person is having or a physiological experience as that makes sense, that's justifiable, that makes sense. And so we are able to do this through the use of our mindfulness skills, that we have to be able to observe and describe what we're seeing and hearing from the other person. So why do we want to do this? Because it's not easy, especially when you're in that moment where it could be such an ineffective interaction that we can't possibly think of what could I validate. And let me also say that validation is not meaning that we approve of something or that we agree. That sometimes, oftentimes, is a myth that, well, if I validate them for that, then that means that I'm okay with what they just said or did. And that is not what validation is. It's being able to share that something, that you see something or that something makes sense with what that person is experiencing. And we'll go through the different things you can validate and the different ways we can validate to give lots of options, especially in those moments where it feels like I have no idea how I could say anything that would feel validating or that I could say in a way that is genuine because it's such a tough interaction. So, sorry?
Then what do you do?
What do you do when you get in those moments?
That moment.
Yes, we will go through it. It's so tough. And so you see, there's a quote up there that a validating response does not directly seek to change or alter a person's emotional experience. Instead, it seeks to highlight the emotional experience in order to facilitate an individual's acceptance and experiencing of the emotion. That I see that you're upset right now. I hear you saying that was really frustrating. That we're not saying like, you shouldn't be upset about that. Like, why are you so upset about that? We're saying, I see, I hear, I'm with you in this moment. So who do we validate and what do we validate? We can validate emotions. We can validate actions, thoughts, beliefs, values, assumptions. We can validate things that are justified, relevant, or effective. I'll often, when we're teaching this in the family program, say to kind of think of it as something that's a personal experience for someone else, that I could never look at Nicole after she says, like, I'm really angry and say, you're not angry, because I don't know, I'm not in her skin. So think of it as anything that's a personal experience to a person, that those are things you can validate, because we can't challenge things that we aren't in that person's skin to know, if that's accurate or not. And we only want to validate the valid. So if Nicole got really upset because I started reading one of her slides, we took a long time piecing these out, and she got upset, threw down her coconut water, and walked out. So the parts of that are valid are the emotions.
Don't do what I just did.
That we can validate that she feels upset. We spent a lot of time putting this together and talking through what might make sense for who reads what. And we can validate the emotion around that and the desire to have things go the way that we would like them to go. What we wouldn't want to validate is her throwing down her coconut water and storming out. That would not be something we would validate or reinforce, essentially. And we also want to make sure that we're practicing self-validation as well as validation of others, to be able to acknowledge and validate ourselves and our own experience, because sometimes that gets swept away in all of it as well. So remember to come back to that too. And that can be helpful to get us to a place where we can validate somebody else, is if we're giving ourselves that space and that compassion and that mindfulness, it can allow us also to connect with others. All right, you don't have to storm out. Oh no, wait, is this me still? This one, okay. So there are two types of validation. There is implicit functional validation and explicit verbal validation with words. So implicit functional validation is validation through behavior. An example here is if somebody's crying, handing them a box of Kleenexes. You don't have to say anything. You hand them a box of Kleenexes, and through that you're acknowledging, you're validating their experience, you're showing you understand. Or giving someone an umbrella when they're in the rain. That doesn't happen here in California, Southern California, so you won't have to probably do that one, but that's an idea. And then there's explicit verbal validation with words. So we're gonna go through the different levels right now, and that's you.
I have a good example of both of those. When I was on my internship here in Boston, in January, my birthday was in January, and I'd gone to the gym and I was feeling good, and I had my big gym bag and my purse to go to internship meeting. And I went into a coffee shop, got a latte, came out, and it was slick, and I literally I just turned for a second and was on the floor. And I didn't even know what happened to myself, and I was like, whoa, now I'm upside down. And this woman just came up to me, her body language, she's bent over me, and I could see her face was so concerned. She's like, are you okay? And I just felt really valid. I wasn't even hurt at all. I just felt really cared for. So that was a much better example than what my face did with Kate. And to answer your question, I think the self-validation is important in moments like that, where it's saying to ourselves, not out loud, but trying to connect with wow, this is really hard right now. And so bringing in that DBT assumption, I'm gonna do the best that I can in the moment, and hope that maybe I even do, that change and evolution that I'm looking for. But really, just taking a minute to say, this is hard. And I think we come from a culture where fast talking is very, we look up to people who think really quickly and speak really quickly a lot of the time. And it's okay to not respond really quickly. It's okay to take a minute, take a breath, let it out, and then say something. And it's even okay to say to the other person, I get that you're really upset, and I'm trying to kind of take it all in. Give me just a minute, because I really want to be in this moment with you, and so I'm just trying to sort through and make sense of all of it. So that's a piece, and that could be something too, as you're listening to your kid on the phone, of oh wow, that sounds like that was a really rough day, and I know it's hard to be there. I know it's so hard to be there, and there's so many rules, and you're scrunched in a house with 10 women, and your group leaders say things that sometimes you don't totally agree with, and we're asking a lot of you, and hoping that just starting with that they'll be oh, okay, the mom understands. Where it gets tricky is if they keep going. Right. We had that today. So that gets a little tricky, but you want to err on the side of validation, and then a little bit of change, and then back to validation, a little bit of change. We call it validation, change, validation sandwich. It might be a triple decker. So we have those two types of validation, which are the behavioral and the verbal. Another great example of that, which happens in my family, is that my mom will walk in when I go to watch football with my dad at my parents' house. She'll walk in during a play and try to talk about something, and it's super invalidating to her, but for some reason she keeps doing it, because we'll both be what, and watching the TV. So you don't want to do things like that. And actually, when we talk about interpersonal effectiveness, I actually DearManned my mom over the years, which is an acronym for the guidelines that we use to ask a request of someone, asking her not to do that, because then later she'll feel invalidated when she says, remember when I said blah blah blah? And I'm no, because the Packers were losing. I was really concerned about the Packers, not about what you were saying. So the levels of validation are, in essence, kind of, it goes from the least nuanced to very nuanced way of demonstrating validation. So level 1 is really that kind of behavioral piece that we're showing, if we're in front of the person, the body language of someone who's like attuned and connected and aware. So that means making eye contact, maybe leaning in, asking questions or what have you. And then level 2 is kind of adding on to that, where we might reflect back almost literally what the person has said to us. This is a great one when you have a loved one who is constantly telling you that you're not getting it if you try to do level 3, which I'll come to in a minute. So if you say, just literally saying back to them, like, I just want to make sure I'm understanding, like you're saying that you're feeling such and such a way, or that such and such happened. And so you're kind of extending, like, I just want to check in with you that I'm getting it. Are we like on the same page? And then level 3, which I never understand why they changed it to that name, because we constantly talk about not reading lines. Marcia. Anyway.
We like to say reading between the lines.
Lines, yeah.
Oh, there you go.
Yeah.
So we want to be sensitive to what's being said and what's not being said, and that's where we can also check in with, like, oh, I wonder if part of the reason why today was so hard is because you told me yesterday that you got your phone back for the first time and you saw your friends on Instagram and you're not getting to hang out with them or something like that. So we can kind of add in things like that. Level 4 is the idea of normalizing and validating around that person's history. So I always talk about that I'm arachnophobic. I've been going out of the house. I grew up, going to Palm Springs a lot, and there were spiders everywhere, and at camp, and the bathroom, in Yosemite, and blah, blah, blah. So I am terrified. It's gotten better. And my family was super invalidating about this, like super invalidating. And so what I would hope that they would say when I come across a spider at this point in life, oh my gosh, I know it's so hard because when you were younger, you would be terrified to go to the bathroom at camp because the spiders were under the toilet. That's not what they say, but that's what they could say. If they were And then level 5 is more or less, when do I do this one? Level 5 is normalizing the current situation for what anyone would experience, what would be a universal experience. And so, you could say that, I have a friend in grad school who grew up on the East Coast and has traveled a lot, but had never lived somewhere where there were earthquakes. And so, like, in our second year, we're living in San Francisco, had a really big earthquake. And he called me and was like, oh my gosh, like, what do we do? My cat's freaking out. And so I was like, I totally get it that, you've not lived through these, and people who haven't lived through these would be really freaked out by that experience. And then level 6, radical genuineness. This is one that comes with a warning sign. It's like, do this one if you really know the person and have a lot of, like, what we call money in the bank with them. Like, you have a lot of built up kind of reciprocity and goodwill. Because sometimes this requires saying how we could be impacted by the other person and being validating about how hard things are going for them. So if someone's saying that they're feeling really suicidal, we can say, in being radically genuine, like, that sounds so difficult and it makes me so sad for you. So we wanna be careful with that, one, because the person might experience you as taking the spotlight off of them and putting it onto you instead of the idea that you're saying, I'm feeling your pain with you. Or they might say, how could you feel you don't understand because you don't feel this much pain, you've never been suicidal. So that's one to be careful with. Okay. This is me. Oh, I see what happened. I made copies, my copies turned gray, and then you went and used a colored one, and that's why I'm confused. Kate.
And to keep you mindful and on your toes.
Alright.
That's hardly awkward.
Thank you. Level 6. Picking it up right away. So a quick guide to validation. We want to pay attention to verbal expressions and words and behavioral expressions. We want to really be attuned to the person's emotions that they're expressing or saying that they're having, the thoughts. People's goals and desires is a really big one. You know, that when you're really depressed and hopeless, it's so hard to connect with those. So when someone does actually express their goals and desires, we really want to put in a lot of validation and reinforce that they're even able to access that, the effort that they're making. We talked about that with the treatment and just getting through a day of treatment, and any effective behaviors that the person does. And when the person's finished talking, we want to share our understanding of what they've said before we launch into anything about our experience or problem solving. And if we feel stuck, share what we've observed in step 1. So it's kind of was saying before, like if we're not sure what to validate, we can go with that kind of level 2 of just reflecting back exactly what we're hearing and asking kind of, am I getting it right, or just sticking with the emotions that the person is describing or looks like they're having. We want to be open to feedback. Sometimes we think if we're cheerleading a lot and really like expressing how proud we are of someone who struggles with BPD, that actually makes them feel more pressure to keep doing well and keep things going at that level. So it gets kind of like antithetical to what we would think would be helpful. So we want to check in, we want to ask for feedback, so that we know what motivates that person, what makes them feel safe and comforted and validated. And again, before problem solving, ask if the person is open to it. Because if we start in with problem solving, the person's not ready yet, that can tend to shut them down. And that is everyone, I think, that doesn't just have to do with kind of BPD, so. It took me however many slides to get what's going on.
Alright. So even when we use our best and most effective validation skills, validation is only validation if the person receives it that way. And all skills are, even again, if we use them and we feel like they're so effective, that doesn't mean the other person is going to be able to be effective or have the skills to have an effective interaction. So what do we do when we're really trying to have things shift and things just aren't changing? That can be so tiring and such a place of burnout for families and the individual who's experiencing that as well. That, again, back to the DBT assumptions, the life of a borderline client is just insufferable. It's horrible as it's being lived currently. That's why people are suicidal, because it feels like that's really the only option, that there's not another option. So when things aren't changing and we're all trying, even when somebody doesn't have the skills or isn't able to, we want to use this skill, which is one of the most difficult skills in DBT, and it's called radical acceptance. And this is one of those skills that it doesn't matter your level of expertise with DBT, it is different dependent on the moment, and it is different in levels of difficulty. So Nicole and I eat and breathe DBT, and this is one of the most difficult skills for us as well. It really depends on the situation, because there are some things that are easier to accept than others. There are some things that are so painful and so difficult that it's very hard to even find like moments of acceptance, and that can change moment to moment. So what we know is that when there's emotional pain, which pain is unavoidable, pain is going to happen. Things that are upsetting or triggering or dysregulating will come for each of us every day on different levels. And when we pair that with not accepting it, saying things like, well, that shouldn't have happened, or why does this always happen to me? That is non-acceptance of reality. And what happens there is that leads to suffering. So we're kind of layering on this extra thing on top of emotional pain, and it becomes so much worse. So radical acceptance is really trying to take a non-judgmental stance and say that this is what it is. I don't have to like it, I don't have to approve of it, this is reality right now. So rather than experience the unaccepted suffering that's intolerable, we want to tolerate the pain that is accepted, and therefore we can move toward managing it. Because we can't change something that we're not accepting of. So first we've got to find that place of acceptance, and then we can work on, if possible, changing it, and at the very least tolerating the moment. So one way that we can do this also with skills is you can bring in your mind and body into this skill. So it's not just trying to hold on to the idea of it is what it is. You know, I don't have to like it, and this is what reality is, at least right now, if it's something that maybe could change in the future. And we can also, to try to get to that place, there's skills such as the half smile. I don't know if anybody's heard of this one, but it's bringing in your body language, because our bodies actually send messages to our brains and how we feel. And so if we're really closed off, if we're really having this tense, closed off body posture, that sends a similar message to our brains, which makes us not quite as open to the present moment. So one way that we can try to move toward acceptance is to use one of the skills that brings your body into it, called half smile, which this is not something that's for anybody else. Sometimes when we teach this, clients will say, well, I used the half smile skill, I walked down the hall and I smiled at somebody. And that actually isn't what the skill is, though it's understandable that that's what we think of, because when we think of smiling, it's often in an interaction with somebody. But this is where you just ever so slightly turn up the corners of your mouth that really nobody even knows that that's what you're doing. And if you try this, you will notice, most people notice, that as you think of the thing that you're having trouble accepting, you feel a shift of some sort. For me, when I first learned about this, I thought like, what? And I had a lot of judgments about it, to be fully transparent. And as I practiced it and tried it, I noticed that for me it felt like kind of like a weight being lifted off of my shoulders. And it can be different for everybody, but that's something that brings in your body into the equation as well. It's not always just the behaviors or the things that we're saying that are skill oriented. It's also knowing that there's a lot of research that shows that the way that we hold ourselves, our posture, our body language sends messages to our brains, which impacts how we feel as well. So this skill, while it's extremely difficult and it's something that's really always in process, it can be so helpful when we get in that place of that things just really aren't changing or aren't at the place that we'd like them to be able to say that this is what it is right now. So we want to also give resources, and hopefully, I think you guys can probably read it okay on here. Yeah, okay. Some resources for anything related to what we've talked about. So there's online resources, there's tons of them, but we've given you some websites that we know are just chock full of a lot of things that can be very helpful. BorderlinePersonalityDisorder.com is the NEA BPD, so the National Education Alliance for Borderline Personality Disorder. That's their website, and on there you'll find tons of resources. It's wonderful. And also, if you guys haven't heard about it, something called Family Connections, which is a really great resource for families to see if there's a chapter that's in your area. They also have Teleconnections, which is slightly newer, but they do phone conference calls, and you can get a lot of support and consultation. Family Connections is a 12-week program that you have to apply for. You get like on a wait list, most of the time a wait list. But it's a 12-week course that really teaches a lot of great skills, gives a lot of information to family members of people who struggle with BPD. And then we wanted to give you guys some literature resources as well. And that's it. I won't go through all those resources, but they're there if you guys feel like they would be helpful. So now we will go through and see if you guys have. Does anybody have questions? And Liz is here to answer any questions that might be related to the programs or like insurance kind of admin questions, and then Nicole and I can do any Nicole questions as well. Any questions?
Awesome. So if you've had something of a volatile relationship with this person, say it's my brother, you know, and the communication history hasn't always been so like loving, validating, and sweet, you know, how would I be able to start validating in a way that doesn't sound phony to him, where he's like, what is it? Where are you coming from, you know, with this language, like, who are you? And it sounds like I'm reading off a script, you know, so that's kind of
Yeah, it can be really tricky because we get in these interactions a cycle, a pattern. So sometimes what I say is just to kind of call it out. If we're starting to do something that's really different, to say, you know, I want to try something new here that might sound weird. I want to see if this can go in a different direction than what it has before. And so I really want to make sure that I'm hearing what you're saying. Is this what you're saying? You know, using a level of validation of, that could be level 3, or you might be, you know, doing level 2 where you're reflecting back what you're hearing them say. But sometimes that's what I say, is just call it out. Like when we have clients that write out a dear man or write out something to share with a loved one, and a lot of the times when they're here in treatment, it's over the phone. And we'll start by saying, you know, if it sounds like I'm reading off of paper, it's because I am, and this is really important, I don't want to forget anything. And so I am actually reading off of something.
And I think also you want to use like the kind of language and tone that you do with the person, and it's just kind of weaving these things in. So I'm totally gender stereotyping here, but if it's a guy and it's his brother, and this is not non-judgmental stance, but if he's complaining about something about work or what have you, and you're kind of like, you know, that's kind of what happens. But you can always say like, well, that's fucked up. You know, as opposed to, oh my gosh, like what a difficult day. You know, like if that's not you guys, if that's not his vibe or way of talking, then it's trying to figure out, you know, just like if you were to validate a kid, you know, you wouldn't use the same kind of like words and phrasing that you would with an adult, because it would be adult language versus kid language, so same thing. Yeah.
Any other questions?
That was a great question.
Yeah.
Yeah.
Thanks, Ryan.
What's a good place, a good way to learn more about, as a practitioner, about using DBT, and are there better sources than others? And you know, I've heard DBT light thrown around, that top, you know. So I'm just throwing it out there as a general
No,
question.
definitely, and they're, you know, when Marshall and him first developed all of this, there was a lot of concern. Once she went through and did kind of the gold standard evidence-based treatment studies that demonstrated that the treatment as a whole was robust.
Mhm.
Oh no, like people only do one part, or blah blah blah, and that's really bad. And so then she did all these studies about, you know, using various components or doing it in various configurations. So behavioral tech is listed on there,
Okay.
and they're the like mothership that has all of the trainings and what have you, and you can do online ones, and most of them I think you have to pay for, and some of them are not super pricey and are more like a couple hours or something like, you know, like this. And then other ones are more in depth, and it just depends on how far you wanna go. I don't know, I wonder if they have something on there that talks about like when it's appropriate to try and do DBT informed or DBT light and when it's not.
Right.
Like I always think of, cause I have private practice, I don't work with clients who have active self-harm or active suicidal ideation, because to me, those are exclusion criteria for one clinician without a team.
Yeah.
And minimal, you know, time for skills coaching. So those are the kind of things I think about, whereas if you have someone who struggles with irritability and verbally lashing out, then you can do a lot of DBT informed
Okay, that
type
makes sense.
stuff. Or if someone who struggles with, you know, avoidance of social situations and things like that, you wanna be doing, you know, kind of the exposure stuff, but you can also talk about the skills within DBT to help the person to navigate the experience of the anxiety.
Mm.
So things like that.
Okay, thanks.
What is the age range of the women in this program?
It's 18 and up. We've had,
70.
I thought maybe almost 80. Or
Well, I'm not gonna ask you,
yeah,
but
yeah,
I had 70, someone had 72. Do we have 80?
maybe not.
So in general, I mean,
18.
like,
In general,
in general, I mean,
The-
that's a big range, of course, but
yeah. Typically,
like the median.
20s and
I feel like there's two, like, you know, kind of.
20s and 40s and 50s,
What's the word? Yeah, exactly.
right?
It's like 20s and then like 30 to 40. It's usually like in college or just coming out of college and made it through college and out, and then either got into a rough relationship or things started happening, work and life is collapsing. Those developmental periods seem to be pretty typical. Mm-hmm.
Is this something that a college student could do, like, once a week? Or I don't really know how this is. Does this like have to be residential? Does this?
Right, it doesn't, yeah. That's what Michelle was talking about in terms of there's outpatient comprehensive DBT where it's one skills group a week, one individual session a week, and then skills coaching calls. And then there's intensive outpatient where they might go 4 days a week for 3 hours, maybe like 2 groups for 4 days a week. Not every group would be DBT, and they'd have one individual session in skills coaching. And then you have where you get into residential levels where they live here. So people, it just depends on how dysfunctional things get for them. If they're not getting out of bed to get to class and to get to treatment, that's why they end up going into residential, because you really have to do like a total reset. But if they're still going and they're struggling with self-harm and they're struggling with depression or anxiety, and they can get themselves to treatment, then they can certainly start at outpatient and really try to turn things around from there. Because if you have to go into residential, it's like things have, the wheels have really fallen off the cart.
So. I'm curious about your experience with the self-identification with the diagnosis. What, what's that been like in terms of both of your experience?
It's a big part of the work. I mean, it's so common because oftentimes that is how the person has felt supported and understood and has made connections is often through their symptoms, their symptomatology. And so that gets reinforced and reinforced. And then there's a big fear of getting better and not having that kind of support or connection, because that's what a lot of the times is what happens, is that that's what the person becomes used to and comfortable with. And so that often is a big part of the work. And in residential, we do get to that. Oftentimes what we're working on are called level 1 behaviors, so the life-threatening, that a lot of our clients are very chronically suicidal and self-harm, and so that's oftentimes what we're working on. And then we weave that in because that is kind of the root. And so doing just a lot of values work can be helpful, and helping the client see or have these kind of exposure moments and interactions where they're really being mindful. So they're using those mindfulness skills to see that they're able to have meaningful interactions and connections with people based on things that aren't just their symptoms or just when they're struggling. That we're getting these moments and these connections when you're being effective or when you're being your normal great self that you kind of lose sight of too.
Is that what you're
I was thinking more about, how.
how we tell them that they have BPD
Yes.
and yeah.
Oh.
Yeah, so that is important too. And I just wanna add something about what you were saying, is that we have a courtyard over here, and so I'll make it a point to try and interact with clients around things that I know are their interests or their, hobbies or what have you, as I'm walking through the courtyard, maybe going to get another client for session, and I'll say, so-and-so, like, oh, what are you reading? Like, I know you really like to read and blah, blah, blah. So that they're not thinking that the only way I get to have your attention is when I'm in crisis. So for example, stuff like that. Or we have a lot of artists and a lot of musicians, and so if I find someone playing alone in here on the guitar, I'll kind of peek my head and be like, ooh, and like try to kind of reinforce that. Mm-hmm.
You hear people coming out as bipolar, very common. I haven't noticed, I don't see people saying, oh, I'm borderline. I mean,
Yeah, of course.
but then there seems to be also some overlap or kind of confusion or misdiagnosis, or maybe they're just so similar, I don't know, but is my observation
Yeah, definitely.
correct? I mean, you don't hear so much, people owning it like people will bipolar now.
Right, no, definitely, I think that goes back to your question, there's still this huge stigma around borderline personality disorder. And I always like to think of it as, I think bipolar has become not sexy, but it's become like accepted or almost like revered, because there's all these movies about people who are bipolar who are like genius, right? That their manic state, all these artists who have produced all this amazing work, it's been in their manic state and and so we kind of idealize that, whereas BPD is still about being ragey and scary and causing people pain and difficult and female, which is also ridiculous because that's not accurate in terms of the epidemiology. A lot of men have BPD, and a lot of times they're either put in the antisocial category or they're put in the bipolar category. In fact, I always forget this football player's name and who he plays for, but there is a football player out there who came out in saying that he has borderline personality disorder and that he has gone to DBT treatment and has all of these has a charity and stuff and website for all of this and what have you. Clearly it's not on my teams that I'm interested in, but anyway, it was really great. And he was African American, which is like huge because culturally that's always a thing of sweeping things under the table. We're getting better. But you know, your question, that slide that had the different areas of dysregulation, there's a sheet that when I was working in outpatient that people would start the first pre-treatment session with, that they talk about the biosocial model, and then they hand the person that sheet and say, hey, like how many of these do you feel like fits for you? Instead of going, here's the diagnostic manual, which looks like this scary like medical thing, and reading off lists, and do you feel like this goes with you, you know, blah, blah, blah. So those 5 areas of dysregulation, I think having the conversation that way feels more validating, it feels more collaborative, it feels really like a relief. It ends up being a relief because so many of our clients, if they come, usually when they come here, they've already talked about having the diagnosis. When I worked with people in outpatient and they had never heard before, or they heard about it in a negative way, when you talked about it in that way, they were like, wow, that is me. And not only is that me, but you're telling me that there's a way that I can take care of myself around this. Like, this is amazing, you know? So that's been helpful. And it's all in the presentation, right? And then I have a very non-judgmental stance thing about bipolar 2. I think that people get diagnosed with bipolar 2 inappropriately all the time because when they're younger and they're going on inpatient units because they're really struggling with BP symptoms, and on an inpatient unit you have this very like small window snapshot of someone's presentation, and you have the psychiatrist immediately saying this is a manic episode, this is a hypomanic episode, and so this person has bipolar 2. And I do believe in bipolar 2. I think that there needs to be a distinction between bipolar 1 and bipolar 2, but so many of our clients come in and they haven't received the being pulled into the direction of DBT, because then their family and their treatment providers are sold on the idea that this really needs to be solved with medication more than psychotherapy and behavioral interventions. So that's where it gets kind of tricky.
Yeah, along those lines, I was wondering how many of your clients here have had many other diagnoses through their lives.
Yeah, I mean, not only do they have a laundry list of diagnoses, they also have a long list of medication, because then it becomes, and I don't knock psychiatry. It's very hard that the psychiatrists are treating each symptom, and so you have like atypical antipsychotics, mood stabilizers, benzos, which is always like, whoa, please don't do that, and then stimulants and anything else? SSRIs. Yeah, or we have people who should be on SSRIs, but because they have a bipolar 2 diagnosis, the psychiatrist is afraid to touch it because they're afraid they're going to push them into a manic episode. So it's very tricky. Our program psychiatrists are pretty amazing because they're very pro like weaning people off of having a long list of meds, and clients don't always want to do that even because they get scared.
Are there any specific criteria, for differentiating between, let's say, bipolar 2 and moving into more borderline? And I realize that's a huge question to ask, but are there certain things even personally as clinicians that help you differentiate what you're seeing and
Yeah, I think one of the things that we really want to look at is looking at the history overall, like making sure when we do the psychosocial evaluation, we really understand their history with relationships, with impulsivity, and like what that looks like. When does that come up? What does that look like when it comes up? And I think one thing that really is helpful for me when I'm making that diagnostic differentiation is asking about their thoughts and what that looks like when they experience, like with bipolar, there's more of the rapid thinking and the thoughts just coming and flooding through. And of course, like the feeling like you're superhuman and the not needing sleep, those kind of things, of course, are markers of bipolar. But really looking at thought content is helpful for me. Sometimes that's really what can help separate it, is what their thought process is like.
Yeah, and what the antecedents tend to be, that there are antecedents that, sometimes people lack insight, they can't, really make sense of the antecedents when they're in the middle of the crisis, but then when you go back and kind of piece together the history. And looking at manic symptoms, or if someone said, a lot of our clients will report things and there'll be kind of it's like 2 standard deviations above and below. Sometimes is how I think about it, they say, I have not slept in 5 days. And then when you really dig deep into it, it'll be, well, I'm sleeping, but I'm not sleeping consistently, I'm waking up a lot at night. So a psychiatrist hears that on an inpatient unit, and they, and again, it's because it's these like snapshot interactions, as opposed to we have more time to kind of hear about the history and then get history, because we have so much face time with them.
Right.
Like, clients are always like, how did you know that? But it's difficult, and we always want to be careful because we don't want to route someone in the wrong direction.
We have time for one more question. Anyone else has one?
This was amazing.
Yeah,
It was great. Thank you so much.
thank you so much.
Thank you, everybody.
Thank you.